I now invite Dr. Jitendra, Senior Consultant from Aster MedCity, Ernakulam, an expert in handling high-risk anesthesia cases, to share his expertise.
Morning, everyone. Thanks to ISA Malnat for giving me this opportunity. It's a big session, actually, traumatic brain injury, guidelines regarding traumatic brain injury management. I'll try to make it more compact and try to give you what is more important, what you need to know when you manage patients with traumatic brain injury. There's a lot of changes, there's a lot of trials like what we have mentioned earlier, crash trials, rescue ICV trials, etc., and DECRA trials, which is latest included in the deconstructectomy along with traumatic brain injury. So all these trials have been included and they've formulated guidelines. So they started off, Brain Trauma Foundation guidelines started off in 1995. Then it was, second edition came in 2007, third edition and fourth edition came in 2016. And what we follow now is the guidelines in fourth edition 2016 is more comprehensive. And there are a lot of inclusions and a lot of deletions which have happened. We'll just go through that quickly. Now, we know the worldwide incidence of neurotrauma is more than 27 million annually, and after that, severe traumatic injury patients are nearly 5.5 million. And there's a very high mortality of almost 20 to 40% patients with severe traumatic brain injury. And those who survive, the morbidity in the survivors, half of them have moderate to severe disability even 1 year following injury. So when you look at the Glasgow outcome scale, you find 50% of these group actually having a lower score of 1 or 2, where they have either died or have bedridden without which they can't move without help, etc. Now, what are we concerned about is primary and secondary injury. So what is primary injury? Basically, it's a mechanical injury at the time of trauma, which is irreversible. You can't do anything about that. Maybe hematoma, hemorrhage, or whatever it is. So that is not reversible. So what is more concern for us as an anesthesiologist intensivist is basically looking at secondary injury, which is more reversible. So these are things which were actually reversible, where you can actually do some manipulations and get the patient survive. So hypoxia, hypotension, hypercarbia, hyperglycemia, hypothermia and edema. And the goals are actually to prevent, our main goal is to actually, when you take up the patient for surgery, when you manage the patient in intensive care, is basically prevent secondary injuries. And the time taken to intervene for these patients is too short. So when you have a patient who's coming to ED and you have a lot of lag, delay in treating the patient, reducing the ICP, the outcome is going to be very bad in those situations. So as we said, why does it matter for anesthetist secondary brain injury, which is preventable? So main thing what you have to remember is avoid hypotension, hypoxia, which actually increases or doubles the morbidity and mortality. So as an anesthesiologist, we have to control the airway, maintain the carbon dioxide levels, control the blood pressure, control the intracranial pressure. These are primary importance when you get the patient immediately into intensive care or when you take the patient for an emergency surgery. So one thing which you have to remember about is we know that there are three components in the intracranial compartment. You have the brain, you have the CSF, you have the blood vessels. So what you can do to reduce all these things and to reduce the intracranial pressure is either reduce the volume of CSF, either increase the cerebral blood flow to improve the perfusion when the ICP goes up, or reduce the intracerebral volume, the parenchymal volume when the brain becomes edematous. So cerebral perfusion pressure is one very major important prognosticating factor, which actually you have values below which it comes down. The hypoxic injury or hypotension which causes the brain damage is reversible, or the mortality or morbidity is increased. So we need to know that the factors which determine the cerebral perfusion pressure would be mean arterial pressure and ICP. There's a difference between the mean arterial pressure and ICP. So to improve the perfusion pressure, you have to either manipulate with the mean arterial pressure, increase the mean arterial pressure, or actually decrease ICP. So we'll come to that later. So the main mechanism is, like what I told you about, is maintaining adequate mean arterial pressure and to prevent excessive rise in ICP. And normally you have the intracranial pressure of 0 to 10, 15 to 20 is taken as a borderline. Above 20, you need to be concerned, you need to take some definitive action to control the intracranial pressure. So vasoconstriction, vasodilatation of cerebral vessels occurs in response to changes mean arterial pressure, partial pressure of oxygen, partial pressure of carbon dioxide, and also blood viscosity. Now, we know that increase in carbon dioxide, PaCO2 is actually causing increase, there's vasodilatation, increased cerebral blood flow, it can increase intracranial pressure, and as well as reducing the PaCO2 to below level less than 25 millimeters of mercury. It's again detrimental to the patient because it causes vasoconstriction and then it reduces cerebral blood flow. So the latest guidelines say that they don't say the terminology is hyperventilation. There is something other thing which they mentioned it as a ventilation strategies. And again, a fall in PaO2 also causes vasodilatation with a consequent rise in cerebral pressures. Now, this is fourth edition of Brain Trauma Foundation. They had categorized 3 categories specific to severe brain trauma injury in patients and adults. They've looked at treatments, monitoring, and threshold. They have looked at all these topics. They have included some studies. They have deleted some studies and come into conclusions. And some of these guidelines, what they have told, doesn't have much of a change. But some of them have actually, the reason behind this, like the studies which are selected in third edition was actually class 1 studies, not much of class 2 and class 3 studies. There were a lot of cohort studies, few randomized controlled studies, and few multicentric studies. So some of the guidelines which they formulated is actually, and some of the guidelines which yet to be formulated in the 5th edition, they're looking at further higher center studies and more centers involvement and coming to data and conclusion. Now, this is a summary of recommendations for traumatic brain injury, the 4th edition guidelines. We'll just go through a few of them. Now, I'm not going to go through all of them. I'm just going to go very few important things. The first thing would be intracerebral pressure. Now, for intracerebral pressure monitoring and treatment, mainstay is to control and treat of intracranial pressures and bring it to the normal levels. So it's an important secondary insult after severe traumatic brain injury, and its elevation plays a pivotal role in providing good patient care to achieve optimal outcomes. Now, you have both non-invasive and invasive methods which can be used to identify or evaluate the intracranial pressures. You have the external ventricular drainage, which is an invasive method, and there are benefits of using extraventricular drainage. And then you have intraparenchymal monitors, like what Goldman monitors. Then EVD actually, how does it help? It actually helps you to even measure the ICP, as well as if the intracranial pressure goes up beyond 20/22, you can actually drain the CSF and then reduce the intracranial pressure. There are certain non-invasive methods for monitoring intracranial pressure, which has been again included into the 4th edition of BTF. That is, you have the pupillometry, optic nerve sheath diameter measurement, transcranial Doppler, and further the microdialysis, etc. Now, as I told you, the measurement of ICP, you have non-invasive, invasive, intraventricular catheters that the EVD remains still the gold standards because you can remove the CSF as well as reduces pressures, and you can repeat zeroing as and when you turn the 3 ways for the measurement as well as drainage. At disadvantages, we have seen few cases who develop ventriculitis, meningitis, etc. when the intracranial catheters are being placed, and it may be again difficult to insert, but it's the most and it's also the most invasive methods. Then you have the intraparenchymal probe, which has got a lower infection rate. It measures the local pressure. That's also being used to the latest guidelines when young patients come in with a diffuse axonal injury, when you don't know whether you have to go for a decompressive craniectomy or not. It is recommended to put in intraparenchymal catheters, measure the ICP, and your treatment for the hyperosmolar treatment is completely based on the intracranial pressure monitoring. And as and when the intracranial pressure monitoring increases, you give the dose of hypertonic saline or mannitol and reduce the intracranial pressures. If it becomes a refractory, then you need to think about a decompressive craniectomy. Now, there are transcranial Dopplers. Again, I told you non-invasive, but there's a limited precision. Then you have a lumbar CSF pressure measure. That's an extracranial procedure. Again, it is an accurate reflection of intracranial pressure that is not routinely used. Now, the latest monitoring recommendations for intracranial pressure is level 2B. That is management of severe traumatic brain injury patients using information from ICP monitoring is recommended to reduce in-hospital and 2-week post-injury mortality. So third edition recommendations were actually ICP should be monitored in all salvageable patients who have a traumatic brain injury but have a GSS of 3 to 8 after resuscitation and has got an abnormal CT. And an abnormal CT scan of the head is one that reveals hematoma, contusions, swellings, hernia, herniation or compressed basal cisterns. And ICP is also indicated in patients with severe traumatic brain injury. Normal CT scan if either two or following features are noted at time of admission when the patient is more than 40 years old or has bilateral motor posturing or a unilateral localizing signs, or if the systolic blood pressure is less than 90. Now, when do you treat the intracranial pressure? What value you have to take it as an arbitrary value where you have to start treating for the intracranial pressures? You have to treat the patient. The latest guidelines say that you have to treat the patient when the intracranial pressure is more than 22 millimeters of mercury. It is recommended because value above these levels are associated with increased mortality. So most of studies which have come up have shown that value beyond 22 has shown a higher mortality and morbidity and a poor outcome. A Glasgow outcome scale after 6 months is low compared to other patients who have been treated quite early. Now, this is the inclusion which has come with the Brain Trauma Foundation guidelines in 2000. That's an update of the decompressive craniectomy recommendations. This is the latest guidelines which has come up, which has been included, which is not in the third edition. What they have said is there are two levels. The level 2A recommendation is to improve mortality and overall outcomes. What they have added is secondary decompressive craniectomy performed for late refractory intracranial pressure elevation is recommended to improve mortality and favorable outcomes. Now, secondary decompressive craniectomy performed for early refractory ICP is not recommended to improve mortality and favorable. These are based on few of the studies which have come up recently. And when you have to think about doing a decompressive craniectomy, what you have to do is a mini craniotomy is not recommended. What they recommend is a large frontotemporoparital, the size of what you see there, is recommended a small frontotemporoparital decompressive craniectomy for reduced mortality and improved neurological outcomes in patients with severe traumatic brain injury. Now, there's a level 2A recommendation for control of ICP which has been recommended recently for the decompressive craniectomy. So, what they have said is secondary decompressive craniectomy performed as a treatment for either early or late refractory ICP elevation is suggested to reduce ICP and duration of intensive care. Again, bifrontal decompressive craniectomy is not recommended. It's a frontotemporoparital decompressive craniectomy which has been recommended. I'll just brush through this. I think time is a little less. Now, updated monitoring recommendations regarding cerebral perfusion pressure. It's a level 2B recommendation where they have mentioned that management of severe traumatic brain injury patients using guidelines-based recommendation for cerebral perfusion pressure monitoring is recommended to decrease the 2-week mortality. And what they have recommended is the target cerebral perfusion pressure value for survival and favorable outcome was between 60 and 70. Whether 60 or 70 millimeters of mercury is a minimal optimal CPP threshold is unclear and may actually depend upon the autoregulatory status of the patient. Now, less than 50 definitely has shown when the CPP is gone, less than 50 it's all shown that the increased mortality and morbidity in all these severe traumatic brain injury patients, and above 70 is actually not recommended. Now, hyperosmolar therapy is another chapter which is actually still being questioned, debated, because there's not too many studies which actually support whether you need to start off hyperosmolar therapy and whether actually it has got a beneficial effect. But the third edition guidelines are still being followed or restated basically because there's not much of studies supporting these, whether you have to use or whether you don't have to use. Another thing what I've seen is whether to use a hypertonic saline or mannitol is a question, and you have to decide upon which patient you have to use hypertonic saline, which patient you have to use mannitol. And there are school of thought where they use both these to reduce the intracranial pressure when it's quite high. But there are studies which are actually showing not much of a difference with the combination as well as independent therapy. Now, recommendations, third edition was actually to give 0.25 to 1 gram per kg body weight of mannitol, and you should avoid giving mannitol when the arterial hypertension with systolic blood pressure is less than 90, and also restrict mannitol use prior to ICP monitoring to patients with signs of, you give it to only signs of patients with tentorial herniation or progressive neurological deterioration which is not attributable to extracranial causes. Now, the Brain Trauma Foundation Committee chose to restate the third edition without much of change. Basically, the rationale for doing so is to maintain sufficient recognition of the potential need for hyperosmolar therapy to reduce the intracranial pressure. That is the mainstay of treatment there, while acknowledging that more research is needed to inform more specific recommendations. So if you have a patient who's not got if you put an intraparenchymal catheter to measure the intracranial pressure, you don't have to start giving the hypertonic saline mannitol without any evidence of intracranial pressure, because that doesn't show much of evidence in most of studies. Now, there's a class 2 group of studies where they have actually evaluated between hypertonic saline and mannitol. What they've seen is cumulative ICP burden was 15.52% versus 36.5% in hypertension versus mannitol. What do you mean by cumulative ICP burden? Is like when the number of days of the ICP catheter which was being placed, they have calculated that, and the percentage of days where the ICP has actually gone beyond 25 has been calculated. Similarly, the ICU days whether the patient has stayed was around 8.5 to 9.8, not much of a difference. But what they have found was hypertonic saline was more effective in lowering ICP burden, but did not have any significant effect on mortality. Mortality ratio was the same for both these group of patients. And there have been studies which I have compared. There's a class 3 studies which you take it as you don't look at class 1 and 2 studies. You get class 3 studies actually what they have compared with hypertonic saline and mannitol. And what they have found, they checked at ICP and Glasgow outcome scale at 6 months. What they've seen at 6 months Glasgow outcome scale, there was no significant difference. Now, prophylactic hypothermia, is it indicated or not? Normothermia is to be maintained. Avoid hypothermia is what has been recommended. And if you look at that latest guidelines with the level 2, what you find that is early, that is within 2.5 hours, and short term, that is 48 hours post-injury. Prophylactic hypothermia is not recommended to improve outcomes in patients with diffuse injury. But if you look at some of the cardiac studies, what they show is a regional, cooling the brain actually has improved the function of the brain when the patient has gone for a cardiac arrest. When you resuscitate the patient, it's not like getting the whole body into hypothermia. That is not recommended. Local hypothermia, cooling the brain, has actually definitely got a good prognostication in outcome of these patients. Now, CSF drainage, again, that is another thing which you have to remember. It's a level 3 recommendation. And EVD system, zero to the midbrain, continuous drainage. I'll just take 2 minutes. CSF may be considered to lower ICP burden more effectively than intermittent use. What you find sometimes when surgeons actually open the EVD drainage catheter, drain 15 to 20 ml, keep it closed. When there is an intraventricular blood, it's not actually recommended. You're supposed to increase the level of the ICP monitor above the tragus, say by 5 or 10 or 20 centimeters, and keep it as a low drain, keep it continuously drainage, so that blood is also drained or the ventricular outflow tract is non-obstructed after some time. But if you do it intermittently, the change in pressures is actually not beneficial for the brain. The recovery of the brain is not going to be very good. And use of CNS drainage to lower ICP in patient, the initial GCS of less than 6 during the first 12 hours after injury may be considered. Now, ventilation therapy, I told you it's not hyperventilation, it's ventilation therapy. You just use as a temporizing measure. It's not, doesn't have a long-standing effect. It's only for the temporary measure of reducing the ICP until you start with the other measures. And it should be avoided during the first 24 hours of injury when the cerebral blood flow is often critically reduced. Hyperventilation can actually cause damage to the brain. Now, analgesics, I'll just brush through that. Steroids are not recommended. That's outcome is poor in patients. It's not recommended for traumatic brain injury. And cerebral monitoring, advanced cerebral monitoring measures are being utilized these days. You have the transcranial Doppler, which is being utilized in the intensive care unit. And then you can actually measure the difference between arterial and arteriojugular venous saturation. Something above 75 is what we recommend. Below 50, the mortality or the outcome is bad for the patient. And measurement of local tissue oxygen, that's a partial brain pressure, tension of oxygen in the brain, where the tissue monitors are placed in the cerebral cortex in the white matter and directly measure the tissue oxygen in the immediate area. The latest something which has come up is microdialysis, that is measuring the brain metabolism. You look at the glucose, lactate, pyruvate, and glutamate, and it's actually a small catheter which is placed in the white matter of the brain, and there's a perfusit which is being flowing at a 0.3 ml per minute, and you collect the sample back again, and this is for the lactate pyruvate ratio or the glutamate value, and then you have to assess whether there's an anaerobic metabolism, where the pyruvate levels may be low, and you can have a lactate pyruvate ratio which is actually higher than 40, which has got a bad prognostic factor, and 25 to 40 has got a poor functional outcome. So it should be less than that. So lactate pyruvate ratio is being assessed during with microdialysis catheter, which is not regularly used in all the institutes. I think some of the major neuro centers do have the microdialysis technique for measuring the brain tissue perfusion. Now, transcranial Doppler is also something which is being utilized in the intensive care unit, where you can actually look at the cerebral blood flow. You can look at whether the post-traumatic vasospasm is set in. If there's a post-traumatic vasospasm set in, then there's a very high chance that the patient can have a poor outcome, or the brain can actually herniate. So you look at the mean systolic velocity, mean velocities, as well as you look at the pulsatility index. A pulsatility index above 1.3 is significant, and the mean velocity of, you look at the MCA velocities, if the mean velocity is above 90 to 120, that is significant, and that can actually give an indirect evidence of whether the brain is actually tense. So finally, to conclude, I would like to summarize a few things. Important thing in management of traumatic brain injury is like preventing secondary brain injury and avoid increase in IC pressures, maintain the cerebral perfusion pressure, avoid hypoxia, hypocarbia, hypothermia, hypo or hyperglycemia, and if required, you put an external ventricular drainage, which can actually give you an assessment of the intracranial pressure, as well as you can use it as a therapeutic measure. And decompressive craniotomy needs to be done when indicated. And one more thing before I conclude, there's a controversy regarding whether to use albumin resuscitation as a fluid in patients with traumatic brain injury. It is not recommended when it has shown that the outcomes have been very poor when you have given albumin as a resuscitation fluid in traumatic brain injury patients. The blood-brain barrier, if it is damaged, you can have a leaky capillaries, you can have the intracellular swelling up of the intracellular compartment, and that actually increases the reverse brain edema, and that's actually not beneficial for the patient. So albumin is definitely to be avoided. The guidelines have taken off albumin from the latest 4th edition. Thank you.
Thank you, sir, for that comprehensive overview.